I'm happy to be here virtually, as will be the case with probably most of our meetings from now until for a while. Um, as Dr. Meyer mentioned, I'm at the University of California, Davis. We are located in Sacramento, actually. UC Davis Health is in Sacramento, along with the School of Medicine and the medical school, the health system, and then our UC Davis uh, graduate and undergraduate programs are in Davis, which is about 20 minutes away. Um, so I just want to give you a quick little background of who I am before I go into my short talk. I was trained in social psychology at University of California, Davis. This was my lab during my PhD program, and this is a group that was part of the Asian American Center on Disparities Research. It was led by Dr. Nolan Zane, and at that time, we were the only NIH-funded center focused on Asian American disparities. And so it was really exciting to be there and for me to learn and to really grow passionate about working in the area of disparities for underserved groups. After I completed my training there, I did a postdoc at UCSF in clinical services research and really became more interested in disparities that affect older minorities. Given just the growing population of older adults in the country and the world and some of the disparities that would face them, just became interested in dementia and dementia caregiving, Alzheimer's disease. And so I went on to do a postdoc at the UC Davis Alzheimer's Disease Center. I was funded through a diversity supplement from the NIA to look at geographic disparities. And I won't go too much into that research today, but again, happy to talk offline if people are interested. And then I started my faculty position in neurology as part of the Alzheimer's Disease Center in 2015. So I've been there for about 5 years in my faculty role. And the areas of interest for me are around diversity and disparities in aging. I'm very much interested in the social and contextual determinants of health and of cognition. So things like the neighborhood and how that impacts cognition, how that impacts the health of older adults. I'm interested as well, I think of it as the antecedents and the consequences of cognitive impairment. So what things precede cognitive impairment in Alzheimer's disease, and then after one is diagnosed, how that impacts the family, how that impacts the person with dementia, how that impacts caregivers. And so the flip side of that is my interest in the development of culturally sensitive, community-based interventions for people who are taking care of family members with dementia. And so that's mostly what I'll talk about today, is the research that I've been doing with the Vietnamese American population in Northern California and developing an intervention for those caregivers. And in terms of just the social determinants of health, this is just a quick definition. It's the conditions in which people are born and they grow and they live and work and age. So we're not, born into, we're not isolated in a vacuum. We are surrounded by the context. And I think that's where the social psychology of what I'm interested in really comes into play, is how people are social beings in a social environment and how that impacts our health. And these things are potentially important because social determinants of health can be modified through prevention, intervention, and policy. The World Health Organization has said that social determinants of health are mostly responsible for health inequities or disparities. And so again, they're the things that are around us that impact our health, and potentially more so for older adults who may be more limited in their mobility, in what they're able to do. And I think this is really the case today, right? That older adults are more vulnerable, and that they may be more impacted by what their surrounding context. And so it's important to look at disparities for older adults. And this is the conceptual model of the research program that I've been focused on over the last few years. It's really looking, the top left box is looking at the individual level factors that impact cognitive health. So these are things like an individual's age, their race, ethnicity, gender, socioeconomic status. And then also the bottom left box shows the neighborhood level variables that I'm interested in looking at. So how does the socioeconomic status of the neighborhood influence one's health? How does the racial ethnic composition, or thinking about these ethnic enclaves, how do those impact the health of older adults, as well as healthcare access and access to opportunities for social and recreational stimulation. So overall, just looking at this, comprehensive model of individual level and neighborhood level factors that impact cognitive health, how that in turn impacts the individual's health, their physical health, their mental health, and then how that in turn impinges upon their family caregivers. So this is just sort of the model that has led my research program. So just to give you some background on dementia and dementia caregiving, we all know that with the growing older adult population, the older population is living longer and they're aging, and with that comes impairments that will require family caregivers and the help of family caregivers. And so it's becoming a significant public health issue. In a 2005 meta-analysis that was published of 100, and I believe it was 116 empirical studies, it was shown that Latino and Asian American caregivers reported greater depression compared to non-Hispanic white caregivers. And this could be for a variety of reasons. It could be that these caregivers are more likely to take on the burden of caregiving in their home, as opposed to putting their loved ones into an assisted living facility. It may be that they have less access to good quality care that impacts their health. And so there are a variety of reasons that this might be the case. And so it really speaks to the need for interventions that really address, that are culturally appropriate and address the needs of underserved caregivers. And one of the most popular interventions, evidence-based interventions out there, are the REACH trials. And this was sort of a multi-component intervention, multi-site intervention that was shown to reduce stress for caregivers. However, these trials did not include Asian Americans, and so it's really unknown what evidence-based interventions are appropriate for Asian Americans, in particular Southeast Asians, who have significant disparities. As we all know, Asian Americans are a quite heterogeneous group, made of many different subgroups, many different languages, many different cultures, and certain Asian subgroups are at higher risk for disparities compared to others. And the population that I'm focused on, just of my background and expertise, is on the Vietnamese American population here, who are at significant risk for disparities. Vietnamese Americans report the poorest self-rated health and the highest disability compared to other Asian American groups. They also report the lowest levels of educational attainment and household income. Compared to other Asian subgroups, they have the highest percentage of individuals with limited English proficiency, experiences of war trauma, post-traumatic stress disorder, loss of social status, resettlement challenges. All of these things contribute to really high rates of depression. As high as 50 to 70% of Vietnamese refugees meet criteria for depression. And part of this is just related to their immigration context. So when you compare them to other Asian subgroups like Chinese Americans or Japanese Americans, they are a relatively recent immigrant group. So after the fall of Saigon in 1975, when the communists took over Vietnam, almost 125,000 refugees fled to the United States. And often this was really a really quick evacuation. So, for example, just to give you an idea, the fall of Saigon happened on April 30th, 1975. And my mom's family was able to leave on a plane on April 29th. And so it was very, very sudden. My mom talks about how they had to trick family members to get on the plane because people didn't want to leave their country, you know, for just to adapt in a brand new country in which they had no English language proficiency. So it was very sudden for a lot of families. And over the next several waves, the next several decades, there were several waves of refugees that came from Vietnam. And all of these different waves, first in the 70s, again in the 80s and 90s, they were all characterized by different socioeconomic status levels, acculturation to the US. So some of them in the first wave, for example, had more connections to the US government, and so were more familiar with the American culture than later waves, who often fled by boat. So these were called the boat people, who had lower socioeconomic status, less education, and didn't have as much exposure to the US. And so there was a lot of trauma that happened before immigration and then after immigration. So a lot of the trauma that many refugees faced were combat and war. A lot of people were, especially if they were men who had connections or who were seen as helping the US government, or who were highly educated, were imprisoned and tortured. Many people lost family members. So I would hear stories from my caregivers about, you know, people just walking one day and the next day no one knew where they were. And so a lot of loss. And again, as I mentioned, sudden evacuation. It was very imminent that the communists were going to take over, and so the people wanted to leave as soon as they could, and so they left pretty much, you know, without any notice. And so there was a lot of trauma for this group, and that's why it's an interesting population to study. And for me, I was just thinking that, you know, just this group that has faced so much trauma over their lifetime and now having to face dementia and Alzheimer's disease in a brand new country, and having to take care of family members for a disease in which many don't understand, is just another level of burden and can exacerbate the disparities that already exist for this group. And so when I was at UCSF, I received a small pilot grant to be able to conduct a qualitative study and examine the beliefs and experiences of Vietnamese caregivers who were taking care of a family member who had dementia or problems with memory loss. So a lot of families may not get diagnosed. So part of the criteria in the study was just that their family member didn't have to have a diagnosis of dementia, but had, you know, reported some memory loss, that they had some problems with their memory. And so it was a small sample of 10 family caregivers who ranged in age from quite young to quite old. And we conducted semi-structured individual interviews in English as well as Vietnamese. Most of them were in Vietnamese, actually, with caregivers. And then we also conducted a focus group to really, you know, look at what were some of the major stressors that caregivers face, and then how do they deal with them? How do they deal with the stress of having to care for family members who, you know, repeated the same questions over and over, or who refused to bathe? And what were some of the things they did to cope with these challenges? And really the whole idea was to start thinking about, for me, an intervention that would address the needs of Vietnamese family caregivers. And so some of the major themes that I'll present have to do with loss and trauma. A lot of our caregivers talked about loss and trauma. They talked about lack of understanding about what Alzheimer's disease was. And they also talked about how the family could serve as a significant source of support, but also be a significant source of stress, because even though there were, you know, oftentimes there were multiple family caregivers involved in the care of one individual. It wasn't just a single person. So it led to a lot of support, but also a lot of stress for family caregivers. So this is just, indicating out of the 10 caregivers that about 7 of them really highlighted this issue of trauma. So for example, there was a 61-year-old caregiver who was taking care of his father, and talked about how his father was really a high-ranking official in Vietnam, but came to the US and then lost it all, had nothing, and how that was very traumatic for the father. And this caregiver felt like that could have contributed to the dementia, just this loss of social status. Another caregiver talked about how she was taking care of her mom, but that her father had all this PTSD, had been involved in war his entire life, and that really contributed to their sort of troubling marriage. And she believed that it could have contributed to her mother's dementia. Other instances, again, people, dying in the camps, in what were called quote unquote re-education camps for people. So a lot of these, again, if they were men, were put into camps. They were tortured to see if they had any ties to the US, and, were seen as traitors. And so there was a significant number of individuals who talked about the trauma. And that wasn't one of the things that we were actually thinking about in terms of the intervention, but it really became a salient point of discussion for a lot of caregivers. It's just the amount of trauma that these families had faced. And I'll just present some quotes to you here. It says, this is a caregiver who's actually 86 years old, and he was taking care of his wife who had Alzheimer's disease. And he talks about the time that he was imprisoned by the communists. And he says, I feel that everything that I do now is nothing in comparison. Talking about how caregiving now is nothing in comparison to what he faced in Vietnam. Because when I imprisoned, it was better to die than to live, and to die in any way. Therefore, I used to bring with me a rope, so when I could not handle it anymore, I would hang myself. So he thought about killing himself when he was in prison. I lived with that mentality for almost 11 years. After I got out of the camp, I saw that my family's life was even more difficult because the communists had stripped everything from us. So my life right now, I try my hardest to live so I can take care of my wife. So this is a man who had faced significant trauma in Vietnam. And then when he, got out of the camp, saw how much his family had been suffering without his support, without his economic support. And so he felt, sort of guilty, indebted to his wife because he was imprisoned. And so he wanted to spend the rest of his life taking care of her, and because she had Alzheimer's disease. So again, just the salient theme of loss and trauma was significant for many of our caregivers. Let's see. Another significant salient theme that came out of the interviews was just a lack of understanding about Alzheimer's disease. And I think this is what's common in a lot of underserved immigrant caregiving groups, not just for Vietnamese, but for others as well. It's just the lack of knowledge about Alzheimer's disease as a neurodegenerative condition. And so this was a caregiver who had been actually raised for most of her life in the US, but was taking care of her mom with Alzheimer's disease. And she talks about how the older generation didn't understand. And she said her uncles and aunts, and so like I said, because of her problem now, they don't even come over. It's kind of sad. This is pretty new for Vietnamese people. They don't understand what is dementia or Alzheimer's. All they see is, oh, she's crazy, and I explain to them, but they don't believe it. And so this caregiver just talks about the cultural differences and the lack of understanding of older generations of Vietnamese who don't understand dementia and don't understand Alzheimer's. They think that it's normal aging until they get to a point where, all of these behavioral manifestations come out, and the families believe that the older person is just crazy. And so it was really hard for this caregiver just to deal with her own family members and to help them understand what Alzheimer's disease was. The last theme that I'll talk about is just how family can serve as a significant source of stress as well as support. And this was a caregiver who was taking care of her mom with early onset Alzheimer's disease. And she talks about how difficult it was for their dad to understand. And she says, I was going through that stage with my dad and just could not understand. I was fighting with him all of the time. I mean, to have some of that better cultural understanding, you know, of where he's coming from. I think part of it is I grew up in this culture and this society, and I don't understand my dad just because he's coming from a totally different place culturally and generationally. The way he sees this disease and illness, I think, is so different. And that's very, it sort of links back to the other theme of just this lack of knowledge. But this lack of knowledge, because these families are quite different intergenerationally, that there was a lot of stress between family members. This was a caregiver who talked about how she tried to convince her dad, you know, mom has Alzheimer's, mom needs to go see a doctor. And he just wanted to take the mom to go see an herbalist, a Chinese doctor who would give her a cure and then she would be fine. And so it was a significant source of stress for this family, her caregivers, because they couldn't agree on how best to take care of her. And so that led, you know, all that study really led me to thinking about how to develop an intervention that would address some of the things that we had just learned from this study and what had been in the literature, the small amount of the small literature that was out there for Vietnamese caregivers. So we had several aims as part of this pilot study that was funded by the Alzheimer's Association, as well as by my K01 from the National Institute on Aging. And the goals were to develop a culturally appropriate intervention for Vietnamese caregivers to reduce their stress and depression, and then to conduct a pilot study of the feasibility and acceptability of the intervention. And at that time, that hadn't really been done in this population. And now there's actually another researcher who's at UCSF that I'm collaborating with who also did a Vietnamese caregiver intervention. But really our goal was to reduce caregiver depression and really improve patient outcomes in a high disparity population. So this intervention was a multi-component intervention that consisted of 6 different classes. The classes centered around topics that we felt were important based on what we had learned from our studies. That education was going to be a salient piece of the intervention. What is Alzheimer's disease? What can you expect? And then adding to that piece of education is the cultural piece. So how do cultural differences in American and Vietnamese cultures affect dementia beliefs? And so we wanted to really address that salient theme about how people in the same family could really disagree on what dementia was, and how do you get family members to be on the same page without getting angry at each other, without, you know, causing more stress. Our next class had to do with skills. So what are the different skills that you need, you know, to utilize to care for your family member? How to navigate caregiving, again, with other family members, family conflict. Resources was another important part of the intervention. So a lot of these Vietnamese families are low income and they don't know what resources are out there. So we wanted to bring in an attorney to talk about advanced directives. We brought in in-home support services workers to talk about in-home support services. So these were tangible things that would hopefully help them in their caregiving. And we, again, I mentioned we brought in an attorney. We brought someone in from the Alzheimer's Association and had live interpretation and translation so that we could provide the entire intervention in Vietnamese. And caregivers were asked to come, and they were also asked to bring a secondary family caregiver. So unlike a lot of interventions where it's targeting one person, just a primary caregiver, we wanted to target a secondary family member, again, because of the collectivistic nature of this culture and a lot of other immigrant cultures bringing in multiple family members so that they could all be on the same page about taking care of their loved one. So it was 6 classes. It was conducted over every week for 6 weeks, and it was about 2 hours each class. And we had a trained interventionist who led the class. Community partnerships were a key part of this intervention. So something that I really wanted to do was to make sure that the community was involved and engaged in this intervention so that it could be sustainable and that we really had a lot of community input. So I partnered with Asian Resources, or ARI, who had been in the community for over 30 years, reaching out to Vietnamese populations. They were a social service agency, but we partnered with them to train to train one of their staff to be able to learn about Alzheimer's disease. And she was, this is her, Thuy. She was the one who really connected with caregivers, recruited, did outreach. We did a lot of community presentations in Vietnamese. We also partnered with ACC Senior Services, and this was the location of our intervention. So it was in the community, so we didn't have it at an academic institution, but it was in a community setting. And we also provided respite care so that caregivers could bring their family member to the intervention, and they had, you know, different activities that their family member could participate in. We had our trained respite individuals, you know, watch different Vietnamese videos. They like sang together, and it was actually a really neat experience. So our pilot participants so far have consisted of 11 individuals in the community. We've done several different cohorts of the intervention. Again, it's meant to be just a small study so we could see if we could actually even do it. The top picture, top left corner, is our first cohort of caregivers, and the bottom was our second, and this was Halloween, and that's why they were all dressed in little, little masks and little hats. But basically what we found is that we, in terms of recruitment, we contacted 87 individuals who had indicated they were interested. Of those 87 contacted, 32 were eligible. And of those, less than half actually enrolled in the intervention, and 11 completed the intervention. So what we found was that a lot of people were interested. Not all of them were eligible. A lot of them were ineligible because they were the person who had cognitive impairment. They were concerned about their own cognitive health. And so we were targeting caregivers. And so, and we also found that even of those who were eligible, a lot of them were too busy, to commit to a 6-week intervention. And so that was something for us to think about after this intervention was over, was how do we develop an intervention and make it sustainable and engage people without being another burden on their time as caregivers. And so we had 11 people complete the intervention. We found that even though recruitment was challenging, once people came to the intervention, they all stayed and they loved it. So all 11 participants came to 5 of the 6 sessions. We were able to administer all of the baseline, post, and 3-month follow-up. And what we found was a challenge, though, was that only 2 of the 11 caregivers brought a secondary caregiver to the intervention. And again, even though we offered that respite care, they were busy and they just couldn't commit to bringing another caregiver because someone else had to stay home and make dinner. So in terms of feasibility, recruitment was very challenging. Retention was easier. Again, once we engaged people and brought them to that first class, they stayed. But it was getting them to that first class that was challenging. In terms of acceptability, our qualitative data indicated that participants found the intervention to be very valuable. And actually, if you want to look at one of our testimonies, it's on YouTube under Vietnamese Caregiver Study, but they talked about how much they really learned from the intervention and how they started to understand what Alzheimer's disease was. And that gave them a lot more empathy for the person that they were taking care of, because they just felt like, at first this person's just being difficult or they're just being challenging because that's who they are. But then once they learned that these were some of the behavioral challenges in taking care of family members with Alzheimer's disease, they started to understand it better and found it really valuable. They also found it really valuable to be able to share and learn from other Vietnamese caregivers. So it's, somewhat isolating to be a caregiver with limited English proficiency. And this was some of the first time for individuals to see that there's other Vietnamese caregivers out there who are taking care of family members. So it really gave them a sense of community and support. And a lot of them continue to communicate with each other after the intervention. In fact, our first cohort developed a support group on their own because they wanted to continue to meet after the intervention was over. They also found the breathing exercises. We did a lot of stress management techniques, breathing exercises to help them deal with their stress. And so those were the things that they really found valuable. The education about AD, the sense of community, learning from other caregivers, learning about what worked for them, what didn't, and the stress management techniques. And in terms of suggestions for future interventions, so even though our caregivers were really busy and it was hard to get them to the first session, again, once they were there, they wanted more classes. So they were really sad actually when the last session was over, and wanted to continue meeting even though the intervention was over. This was again, it's only 11 people, so there's not much that we can, gather, but I think this just gives us a good idea that the intervention seems to be helping people a little bit, that the post-intervention are the orange bars, pre-intervention measures are the blue bars, and you can see that overall the things that we wanted to go down, like burden and stress, they did go down a little bit. And things that we wanted to improve post-intervention went up, things like self-efficacy and symptom management, self-efficacy and knowing how to use support services in the community, that went up. Knowledge of Alzheimer's disease went up. And so some of the other things didn't change too much, whether or not they actually intended to use services or the quality of life for the care recipient didn't change very much. But overall, it seemed to indicate some preliminarily positive results of the intervention. So just really recently, we extended the intervention to San Jose. San Jose has a large population of Vietnamese caregivers, or Vietnamese rather, and so more caregivers. But it was great to be able to do it there. And as I was doing this more and more in the community, there's definitely a strong demand, and the Vietnamese community really wants these engagement and educational workshops and opportunities, and it's just figuring out how we can sustain this once the funding is over. And so those results will be looked at, will be analyzed soon as well. So in conclusion, I think that it's really important to study racially and ethnically diverse caregivers. And one of the things that I didn't talk about today, but that's really important, is looking at not only diverse and underserved caregivers, but looking at caregivers who are taking care of their family members across the spectrum of Alzheimer's disease. So right now, I actually just got funded an Alzheimer's Association grant to look at caregivers of people with mild cognitive impairment as well as people with dementia, because there's, in the MCI stage, there's that level of uncertainty for caregivers about what's going to happen. And so stress for them might look quite different from stress of caregivers taking care of someone with dementia. And so that's really important to look at, and looking at how caregiver factors is something that if we are able to change burden and stress, that could really be related to a change in patient outcomes. And you can see that if caregivers are really stressed, they might, lash out more towards the person with dementia, and thinking about how that might impact the person with dementia and their outcomes. And so that dynamic is really important to look at, and that's something that I'll be looking at next in my caregiver study. And again, looking at how caregiver factors impact patient trajectories over time. So that's what the new grant is going to be looking at our cohort of caregivers at the Alzheimer's Disease Center, and looking at their trajectory of burden of stress over time, and looking at how that impacts the person with dementia. Given that there's really no cure, no way to slow or stop the disease progression, if there's something that we can do for caregivers and for their families to help the person with dementia, that's what we're hoping to do through this next opportunity with Alzheimer's Association funding. The last thing I'll just say really quickly is that Asian Americans have for quite some time not been included in research in aging and Alzheimer's disease research. And that, it's not easy. They're such a diverse group with different languages, so it makes it more challenging, but we have to start somewhere. So we were actually funded just recently by the National Institute on Aging through an R24 grant to develop a registry of Asian Americans and Pacific Islanders in research. And the goal over the next few years is to enroll over 10,000 Asian Americans and Pacific Islanders into a research registry for aging research in California. And so this is a multi-site study. The lead institution is UCSF. It's led by Dr. Van Park there, and we're a site for enrollment. And it's really directed through many, many community partnerships through a community advisory board. And our goal is to continue to address some of the disparities that impact Asian American and immigrant populations. So with that, I just want to acknowledge my funding sources and the faculty and staff support I received from the Alzheimer's Disease Center through my NIKO1, as well as Alzheimer's Association, as well as through the community partners that I definitely could not have done this without, and my research assistants and the many families that I've been able to interact with over the last few years. So with that, I'll go ahead and end and stop the sharing, and I welcome any questions.
Thank you so much, Juan. This has been a wonderful presentation. We have participants, I think, from all over the country. So I have my own questions, but I won't take the privilege. I will rather give the opportunity to my colleagues. So any questions from the Valley or anywhere else?
Hey, thank you. I'm Andreas Holzenberg. Dr. Meyer, you have a wonderful name at the interface of Vietnamese and German language. I love it.
Thank you.
And I was wondering, it's more a semantic questions. When I think of interventions, I always think about directed to the patients. Here you're presenting a wonderful, almost like a training opportunity for caregivers. Why do you call it intervention?
Yeah, I think it is just semantics. It really is a training. It's an intervention in the fact that some of the components of it are from other evidence-based interventions that have been shown to work with other populations. And so we basically adapted these evidence-based interventions and tailored it to the Vietnamese caregiving population in the hopes that they would learn some strategies and yes, you're right, get some training to be able to take care of their family member.
Okay.
Yeah.
Gives us good ideas. Thank you.
Mm-hmm.
Hello. So really enjoyed the presentation. I actually have 3 questions. I'll start with one and then let other people ask so I don't hog up the time.
Sure.
The first question is, I think that what I really liked about your presentation is that it shows the importance of getting to know the community and the strength and power of a more qualitative approach.
That's
so
right.
I guess my question is now, for those of us that might be working on, trying to brainstorm or writing grants or papers where we're thinking about this in terms of sort of using either, I don't know, approaches, technologies to do really good, high quality, qualitative research. Could you give us maybe some advice about what tools you use? Is there particular software you use? So anything that you could help us in terms of the focus groups and capturing all of that information? Because that I applaud you for doing that work, because that's how you start. Even, I talk about even in genetics, you have to know your phenotype. And this is an important, very important first step.
Right. Yeah. And, qualitative research was something that I had not been trained in during my PhD program, but I really did feel like, one, it was a great way to explore some of the things that are not, that don't typically get presented in intervention research. And so I had to start from a basic foundational approach. What are the experiences of caregivers beyond Vietnamese caregivers beyond what's in the literature? You know, it might be different for my geographic population in Northern California. And so I partnered with a geriatric psychiatrist who had a mixed methods background expertise, and started learning how to do qualitative research. And I felt like it was a really great way to build rapport as well with caregivers before we engage them in an intervention, because a lot of caregivers want to talk about, you know, what they're going through. And so in addition to collecting data, I felt like it definitely increased the rapport that I had with the caregivers and with others in the community. And I really love doing the interviews. The qualitative data analysis is very challenging. Actually, it takes a lot of time to transcribe the data, especially if it's in another language like Vietnamese. You have to, transcribe it verbatim. And then translate it to English for analysis. And in some cases, you can do the analysis in that particular language. But for me, I felt more comfortable doing it in English, so we had to translate it to English. And so that part takes some time. It takes a significant amount of time. But I love doing the interviews. The analysis was more challenging. And I used Deduce software. DEDOOSE, and it's a program that was developed at UCLA. And I have found it to be quite useful. It's the only program that I've ever used. I know that a lot of people use NVivo, but I use Deduce, and I have found it to be really productive. So yeah, hopefully.
Can you repeat that one more time? Sorry, I'm trying to take notes while you're talking.
Yeah, no, it's Deduce. It's spelled DEDOOSE. Deduce software. Yeah.
Awesome. So one question I have is how do you compare your findings to other minority groups such as Hispanics, for example?
Yeah, that's a great question, Gladys. I think a lot of the stressors are very similar. And actually, I think there's a lot of similarities between a lot of the Vietnamese and a lot of the Latino groups, because similar socioeconomic status, similar in terms of degree of language proficiency. The stressors, I think, in caregiving sort of cross cultural barriers. It's just challenging when someone, refuses to do something that you ask. That's gonna be stressful for everybody. I think some of the social context in which the caregiving occurs might be different. If caregivers are more likely to live in a multi-generational household, then there might be multiple caregivers taking care of someone. And so how to deal with it, sharing those responsibilities, negotiating the caregiving task, coming up with a calendar, things like that, I think might vary across cultures. Just the degree of the social aspect of caregiving, and not so much, I think, the stressors.
Thank you.
Mm-hmm.
Do we have comments, questions?
I guess maybe I'll ask another question. So
Yeah.
I can go on and on. I'll stop it at some point. But so another question I had was this idea, which I'm sure you've considered, is a lot of communities are really multicultural. And I'll give you one example. One thing I've noticed, especially for Latin America, is that people will put, Hispanics and Latinos in one box. But there are a number of individuals that are also of Asian descent. Brazil, for example, right, I think has the largest Japanese community outside of Japan. Mexico and many Latin American countries have individuals that are Chinese.
Right.
So for people that have this kind of mixed kind of cultural background, it probably presents, unique challenges. So do you have any advice and here we have some people are American and Mexican, or American and Central American, or it can be complicated. So do you have any advice for working with multicultural communities?
Yeah, that's such an excellent point. I really haven't thought about that. Most of the families that I've interacted with have all been mostly Vietnamese, and so, but I think that is an excellent point that will become more salient as the as people as time goes on. You know, that there's more multiracial households. Um, how to deal with the cultural influences that affect caregiving. And I think even, you know, in the families that I saw who were Vietnamese, but who were raised mostly in the US, like the dynamics of the daughter who was taking care of her mom who completely disagreed with her dad. I think a lot of those cultural issues will be more salient with with multiracial households. And I don't know that there's been a lot of research in terms of caregiving interventions in multiracial families, multiracial households. So that would be really interesting to look at. Yeah.
I totally agree.
Thank you.
The other thing, one more of the support programs are actually longer, much longer. And
Yeah,
some
right,
say
right.
that they, in order to actually have a sustained behavioral change in the caregiving, meaning that they adopt behaviors that where they can apply what they learn. It's longer. I noticed that yours is six sessions, right?
That's right. Yes.
So
Yes.
is this, you know, what do you plan? Do you advocate for 6 weeks, or is this something that you are kind of tempted to actually look at the right doses of sessions for caregivers change in behavior?
Yeah, that's an excellent point. I know a lot of the sessions, when I was sort of reviewing the literature and thinking about how to adapt our intervention, you know, for example, the REACH trials were 12 sessions, and a lot of these, you know, other sort of CBT-based interventions are 12 sessions. And when I think I had brought that up in different interviews and focus groups, people were saying there's no way that Vietnamese are going to participate in 12 sessions, you know, when you ask them. They just don't have the time. And this is, you know, the idea of participating in a research intervention and filling out questionnaires and being followed up over time is not it's not common to a lot of Vietnamese. And so we try to strike a balance between figuring out what were the essential elements, what were the essential evidence-based elements that we could put into this intervention, and basically cutting that time in half to 6 weeks, and still have it be, you know, productive and effective. And we felt like 6 weeks was going to be what would be feasible. Now we haven't tested it with longer, although I will say that after, you know, the intervention, a lot of our caregivers wanted more. And so they, you know, I think it's just engaging them at first. I think if we tell people 12 sessions, it's going to completely turn them away. But I think in the future, what might be possible is to say, you know, between 6 to 7 weeks, and then really tailor it by, you know, telling caregivers, hey, if you need more support, there's the option of continuing on in the intervention, and really making sure that we can target that behavior change and make sure it's sustainable, and that they will continue to carry out what they've learned. But I think when you first engage the population, it's almost like you have to like be very, you know,
Pragmatic.
pragmatic and gentle with what you're proposing, you know. I think credibility is also really important here, and that's partly why I partnered with the community organizations, because there needs to be that level of credibility. I think just the fact that, you know, I'm a doctor is not enough, right? And the fact that I'm somewhat young, although my children would not say that, you know, you have to strike that level of credibility before you ask for so much. And I'm sure that a lot of you know that, especially when working with, you know, diverse populations. And so it's important to ask what's feasible, and then maybe later we can increase our ask once we've built that initial credibility.
When all your sessions were delivered in person?
Yes.
There were any participants over, phone or, and do you think your intervention is suitable for delivery, to be delivered by an agent that is not a healthcare professional, such as a peer that it's trained, or a promotora, for example?
Yeah, I mean, that would definitely help make it more sustainable, I think, if we could do it over the phone, if it could be a peer support program. For our interventionists in the first couple of cohorts, she was a trained LCSW. And then in San Jose, we had the director of the community agency, the executive director, deliver the intervention. But I think, yeah, in the future, it would be great to be able to have it peer-led and make it as easy and as convenient as possible for people to participate. Yeah, that's a great idea. Mm-hmm.
You hear me?
I have to thank Dr.
Yes.
Mestre for putting my records straight, because I put a note down here, 6-week intervention regime, meaning 6 times 5 days.
Oh.
I thought, this is cool. They really go to town.
No.
But okay, so it's only 6 times 1 day, okay. But what Dr. Gill was saying also, we talked about a lot about the Hispanic or Latino paradox, where under suboptimal environmental conditions, people have a higher level of longevity. Is there any type of paradox known for the Vietnamese population?
You know, there's really not much information on the Vietnamese population out there. I would say that the model minority myth also applies to this group, and that's just the stereotype that, oh, Asian Americans do quite well socioeconomically. I don't know about health-wise, actually, but I would say that they fall under that category, even though they're quite different. And we really don't know a lot about their outcomes in terms of cognitive health, especially in Alzheimer's disease.
Dr. Meyer, congrats for your presentation. I really enjoyed it. I wanted to ask you something about, you have a psychology background, and you talked about a lot about the data about trauma, pre and post migration trauma. Are you planning to do something with that data in the future? And what other things are you planning for new interventions in this group?
Thank you for that question. That is something that we actually had submitted a manuscript looking at just qualitatively the trauma that a lot of the caregivers talked about. And so that in that paper, we really drilled down a little bit more into specific types of trauma, and really what came about from those analyses were that it had to do with trauma related to death or loss of family members, trauma that came about from losing the status that was once held in Vietnam compared to coming to the US. And I'm trying to remember some of the other themes, but I think that it is a significant piece for the Vietnamese population, and I think will continue to impact, generations, the younger generation as well. But yes, that is definitely something that I'm continuing to look at. And in terms of interventions, what I would hope to do in the future is to be able to provide, to conduct a multi-site trial of the intervention that we had done here in Sacramento and in San Jose. For example, Houston has a really large Vietnamese population, and I was actually supposed to go there last week to do a talk at the University of Texas Medical Branch, and talk about potential collaborative opportunities for doing intervention research with Vietnamese, but that talk was canceled, so I wasn't able to go. But I'm definitely interested in being able to extend this intervention to outside the Northern California area.